We'll move on to my dear friend from Perth, Dr. Vignesh Raja, talking about strategies for zonular dialysis. Vignesh.
I'd like to thank the Ischemic Society of India, Dr. Sahu and Dr. Boramani, and my colleague and mentor, Prof. Verma, for this invitation to speak at this meeting. So I'm going to talk about strategies for zonular dialysis, and because I thought it was an SICS course, I should only present cases where we've done SICS for zonular dialysis. So this is a video that was, because normally we do lots of phaco in Australia, so I borrowed this video from my good friend and colleague, Minu Mathan. So let me play the video. So here you can see that as you're doing the rexus, the lens is very wobbly, and you do very gentle hydrodissection. And looking at this, you can see how wobbly the lens is, and you can see one of the poles of the equator already lifting. So the next thing is, when you're trying to tumble the lens out, you don't want the whole bag to come out and vitreous to prolapse. So here we're using iris hooks for the bag, so that we keep the bag stable, and insert a CTR through the side port, because it's nicer to insert it through the side port, because the CTR you don't deform it too much. You actually follow the curve and it goes in very nicely. After gentle hydrodissection, we just tumble out the lens very slowly, and then with the vectis we take the lens out. So back then we used to put lenses in the bag, but now the thinking has changed, because with the advent of capsular phimosis, these lenses can decenter. Even despite putting a CTR, they can still decenter. So now the current thinking is that we put a 3-piece lens in the sulcus with optic capture. So when you have an unstable bag, I think that is the preferred way to go, because these lenses don't then develop late onset capsular phimosis, and they stay well centered, and they also don't decenter as well. And again, when there is a CTR, always strip the cortex tangentially and not radially, because then it's easier to come out. And best is to put a 3-piece lens in the sulcus. This is of course when you do it with mild degrees of zonular dialysis. But this is a case where I am doing this. This is a case in Australia, and that's why in the Magic of SICS session part 1, I said that every phaco surgeon needs to know SICS. You're not a complete cataract surgeon if you do not know SICS. This is a black-brown cataract sitting in the anterior vitreous of an indigenous person in Australia. So here, because it is more than 8 clock hours of zonular dialysis, I've decided to do, you can see the lens tilting down into the vitreous. And I thought to myself, I think rather than doing that, I'm going to do what I'm most comfortable with. I'm just going to remove the whole lens, do vitrectomy and scleral fixate a new lens, or you can even put an AC IOL depending on the surgery that you're more comfortable with. So I mark 2 sclerotomies 4 millimeters apart on either side of the limbus. And because I want to tamponade the vitreous as much as possible, so that's why I put dispersive viscoelastic, and I take out the whole lens. And now I put a suture just to maintain anterior chamber stability again, because you don't want more vitreous prolapsing out, because if you do that, then by the time you go in and do a vitrectomy, you will find a tear or a detachment. So I first clear the vitreous from the anterior chamber, and this was in the pre-Luxgood era. So I was using an Alcon CZ70 BD lens, because we've got such a big tunnel anyway. So I'm passing CB8 Gore-Tex suture, and I'm externalizing the suture, and then put the lens in. Because we've got a big tunnel, this lens goes in straight away, and it's very well centered, because it's a 7 millimeter optic, and it's a very big lens. So these lenses always center very, very well. And the best part about using the Gore-Tex technique this way is you're not blindly railroading a needle So, we've cut off the needles and it's very controlled, through the trocar cannula system. And once you pull out, all the sutures, all the cannula, the sutures are there just to be tied up. And now instead of suturing the conjunctiva, I just suture it with glue, like how we do pterygium surgery. So apart from closing up the scleral wound, and we have to make sure that we bury the knots inside, because if you leave the Gore-Tex knots outside, you'll get scleral necrosis and conjunctival erosion there. So to summarize, for zonular dialysis cases, when you're doing SICS or phaco, it's always better to have a large rhexis, at least 5.5 millimeters, because with late onset capsular phimosis, that can cause further decentration of the bag, intraocular and CTR complex. So, and you can use capsule hooks, like either the iris hooks or capsule hooks, like Chang capsule hooks, because the Chang capsule hook goes all the way to the equator of the lens and supports that, and then you can place a CTR. And again, depending on the degree of zonular dialysis, you can use a single just a normal CTR, a single CTR with a single Cioni ring, or CTR with double Cioni ring. And for lens placement, you can either do SFIOL, ACIOL, or iris clip, or a 3-piece lens in the sulcus with optic capture. And thank you all.